Tantor Audio, a division of Recorded Books, presents Anti-Vaxxers, How to Challenge a Misinformed Movement by Jonathan M. Berman. Narrated by Daniel Henning. Preface. Most of this book was written in 2018 and 2019, before the onset of the global COVID-19 pandemic that rages as I write this preface. In January 2020, I started watching news of the pandemic closely, and I started examining how people on the internet reacted to the news. A Reddit user posted an analysis that they claimed showed that the Chinese government was lying because the number of new, at the time called 2019-nCoV, cases fit better to a quadratic regression than exponential. I started examining the published epidemiological numbers on the epidemic, and because I'm not an epidemiologist, I didn't believe that I had run the analysis correctly. The model I ran predicted that in the United States, if COVID-19 became common, as many as 4 million people would die. It seemed an impossibly high number. Surely I had misunderstood a variable. In February 2020, a medical student who was doing a fellowship in a congressional office asked me about the outbreak in China, and I showed her my analysis. I included a figure with the effects of reductions in potentially infectious interactions being reduced in increments by 0%, 20%, 40%, 60%, and so on. The figure showed that if interactions were reduced by 40%, it would buy scientists time to study the new disease and give physicians time to treat it. I warned her that the state I live in has a limited number of hospital beds. I did not anticipate a shortage of ventilators, masks, or toilet paper. Later, someone presented a much clearer figure that showed the same idea. If we practiced social distancing by isolating ourselves and minimizing our interactions with other people, we could slow the spread of the disease. As the nature of COVID-19 became clear, a global pandemic was declared, and individual businesses, universities, cities, and states started to implement shutdowns. But politicians were slow to respond. Some downplayed it by comparing it to seasonal flu, which is widespread and kills tens of thousands every year, but which the current healthcare system can mostly handle. Some, watching the stock market lose value, floated the idea that the death of the elderly was an acceptable sacrifice to ward off an economic recession. Worldwide, there have been reports of individuals ignoring the warnings of scientists and public health offices, going about their daily lives as if nothing unusual were going on. While anti-vaccine activists won't be relevant to the current crisis until a vaccine is developed, tested, and brought to market, the behavior of people who have ignored lockdowns or left quarantine to attend parties shares some similarities. In South Korea, a woman refused testing despite showing symptoms and infected dozens of others by continuing to attend church. In Kentucky, young people defied state guidance to stay home and threw a coronavirus party, where a partygoer infected at least one other. In Florida, college students gathered at beaches to celebrate spring break. Said one, "If I get corona, I get corona. At the end of the day, I'm not going to let it stop me." Later, some students who had gathered in Florida tested positive for SARS-CoV-2, the virus that causes COVID-19. Large churches have continued to hold services with thousands of attendees despite state orders. Liberty University reopened amid the crisis. U.S. Senator Rand Paul was tested and continued to gather with other lawmakers and use the Senate gym for several days before his results returned positive and he began self-isolating. Some large churches have continued to hold services with thousands of attendees. We are early in the pandemic, and it's likely that these anti-social distancers will be studied in depth in the coming years. However, some traits seem to stand out: a lack of trust in medical authorities, a misunderstanding of the scale of human suffering that infectious disease can impart, ignorance of science, and a tendency to make comparisons between SARS-CoV-2 and seasonal flu. The toll that flu takes every year is indeed steep. According to CDC estimates, each year tens of thousands of Americans die due to influenza and its complications. But influenza differs from SARS-CoV-2 in some important ways. First, each year a vaccine is developed which allows for some protection against influenza. Influenza also appears to be less contagious than SARS-CoV-2. Someone with influenza infects about 1.3 other people on average over the course of their infection. It currently appears that someone with SARS-CoV-2 infects about twice that many. A greater percentage of people suffering from COVID-19, up to 20%, require hospitalization, and a greater percentage of those who require hospitalization die. New, as of late March 2020, evidence suggests that a large portion of those who test positive for SARS-CoV-2 are totally asymptomatic and capable of infecting others without realizing it. Together, these features make SARS-CoV-2 significantly more dangerous than seasonal influenza, because it can spread rapidly and overwhelm hospital systems, which are typically built with little overload capacity. Already, Italy has suffered greatly under shortages of personal protection equipment such as masks, as well as equipment such as ventilators, and similar shortages are anticipated in New York and other areas of the United States. The apparently high proportion of asymptomatic carriers of SARS-CoV-2 seems to encourage anti-social distancers. Owing to an early shortage of testing materials, tests were available only to those meeting very specific conditions. However, it is becoming clear that a high fraction of those who have been infected show no symptoms at all. Many who should have been quarantined have been free to travel without realizing that they were spreading disease, including some who went out of their way to travel and continue to meet up with others. Complicating this in the United States has been a partisan political response to the pandemic. So far, large, densely populated cities have been the hardest hit, and less populated rural areas have not yet seen infection rates as high. The urban-rural divide underlies much of the political disagreement in the United States, and this has been reflected in polling that shows that the degree of concern people have about COVID-19 is heavily dependent on their political leaning. Some partisan news sources initially downplayed the severity of COVID-19 and took cues from politicians who seemed to want to reopen businesses that had been closed due to social distancing, regardless of the cost in human lives. Similar partisan responses have occurred in other countries. In Brazil, President Jair Bolsonaro has publicly called for reopening businesses and has continued to go out in public denying the severity of COVID-19 and attempting to undermine regional governments' efforts to shut down. Bolsonaro was quoted as saying, "Some will die. I'm sorry. That's life." One thing is certain. Life has changed for millions of people around the world in this crisis. It has forced many who grew up in an era and location where infectious disease was not confronted or dealt with on a daily basis to confront the dreadful facts of a pandemic. Personally, I have shut down my lab and may travel to the state capitol in a few days to volunteer in the public health lab testing samples. The nature of such fast-moving events means that much of this note will be outdated by the time you read this. However, I hope that this book about anti-vaccine activists gives some insight into anti-social distancers as well. Introduction. The broad class of treatments collectively referred to as vaccines has been instrumental in eliminating some diseases, severely reducing the incidence of others, and helping to reduce the overall incidence of infectious disease as a cause of death. Vaccines have significantly reduced the burden of human suffering. Their story is one of the great tales of human progress and our ability to develop tools and knowledge that allow us to improve our quality of life. Nevertheless, some people oppose vaccination vehemently. Although many attribute the modern anti-vaccine movement to Andrew Wakefield and his 1998 paper purporting to link the measles, mumps, and rubella vaccine to the development of a kind of late-onset autism, opposition to vaccination is not new. Since the first smallpox vaccine was invented at the turn of the 19th century, there have been opposition to vaccination. In the case of the first vaccination, this opposition may have been justified because an uneducated farmer used a darning needle to acquire pus from an infected cow's udders and then scratch his family members. These historic anti-vaccine movements have much to teach us about the modern anti-vaccine movement. Wakefield's paper followed decades of anti-vaccine rhetoric in the 19th and 20th centuries. This rhetoric was driven by changing views on bodily autonomy, the role of the state in medical care, fears held over from the rollout of the first polio vaccines, and an earlier scare surrounding the diphtheria, tetanus, and pertussis vaccine that started in 1974. The vaccine scare of the 1970s and 1980s carried through to the 1990s, forcing several vaccine manufacturers out of business. Although Wakefield's paper was one of many proximate causes of the modern anti-vaccination movement, it received widespread press attention, far more than did subsequent papers that did not support its conclusions. We will look at questions about the interface between news media and science, as well as at questions about how fake news spreads faster than real news. Over the last 2¼ centuries, this opposition has been driven by several motivators: fear of adverse side effects, objection to government intrusion in the body, conspiracy theories about big pharma, the financial motivation of those selling alternative treatments, and of lawyers seeking to sue drug companies, fear of Western or colonial intrusion into communities, rejection of the idea that anyone but a child's own parents might know what's best for them, and a sense of community and identity built around parenting choices. This opposition has caused real harm over time, including deaths from outbreaks of smallpox, measles, and polio, bankruptcy of vaccine manufacturers leading to shortages, and personal heartbreak as divisions sown by anti-vaccine activists have damaged family relationships and friendships. Despite these setbacks, overall vaccination rates are high worldwide, and anti-vaccine activism is still a niche pursuit. However, small enclaves exist where anti-vaccine rhetoric has been effective, leading to clusters of unvaccinated children. These clusters put at risk those who, for a variety of medical reasons, may not be able to vaccinate, and have led to outbreaks of chickenpox and measles. 3 broad strategies have been used to sway people from anti-vaccine beliefs. I refer to these as reactive, information deficit, and community-based strategies. A reactive strategy of engaging directly with anti-vaccine advocates on the internet and mocking them or arguing with them is the least effective. Not only are vocal online anti-vaccine advocates not representative of the average person with vaccine doubts, but this strategy can backfire, resulting in more entrenched views and damaged family relationships. When anti-vaccine activists cite specific articles or use the language of evidence, typically they are aiming to justify beliefs that are held for non-evidence-based reasons. Addressing an argument without addressing the underlying emotional reasons for a belief is unlikely to be effective. When opposition to vaccination becomes attached to a person's identity and values, contradictory information can feel like an attack on that identity and those values. Information deficit strategies approach vaccination by making factual information about vaccination available to the public through, for example, websites, internet resources, and fact sheets. While presenting information resources to the public has been successful in increasing the intent to vaccinate, these strategies require those with questions to seek out such resources in the first place, and then to know which of them are trustworthy. These strategies are not likely to be effective for entrenched anti-vaccine activists, but can be effective for those with questions or doubts. Community-based strategies, which I believe to be most effective, are strategies based on showing those with doubts that others in their community are vaccinating their children, that their peers in their mosque, synagogue, church, or temple, who are also good parents, have vaccinated their children, and that vaccination is an expectation of any good parent. Community-based strategies have been used in the wake of measles outbreaks, exacerbated by anti-vaccine activism, and resulted in significant increases in vaccine uptake. These strategies take into consideration the self-identity and values of those who are being targeted by anti-vaccine rhetoric. This book presents information that fits with all three strategies. It refutes many specific claims made by anti-vaccine activists. Those seeking more details on these claims can look to additional resources, such as Paul Offit's books or Seth Mnuchin's The Panic Virus. I have endeavored to balance not providing an additional platform to anti-vaccine activists with addressing some of their most prominent and visible claims. There is an inherent tension in seeking to understand a movement while simultaneously refuting its claims. In this case, these goals are not truly at odds. There is no single organized anti-vaccine movement. There are many individuals who have been influenced by a specific set of beliefs. An important part of understanding those beliefs is understanding if they are true. I doubt that a reader approaching this book with entrenched anti-vaccine views is likely to have her or his mind changed. However, many have encountered conflicting information about vaccines or heard negative information from friends and relatives, but don't necessarily know enough about the topic to form a strong opinion either way. Others know about the importance of vaccination, but would benefit from a deeper discussion of the history of the anti-vaccine movement when having an informed discussion about it. We will explore the motivations of anti-vaccine advocates, including those with strong financial incentives, such as those selling alternative treatments. Otherwise good, well-intentioned parents who've gotten bad information, and internet activists with myriad techniques and means of spreading misinformation. We will explore some of the psychological effects that make these techniques effective in spreading information, and the means by which those with good information can work toward meaningful change in the laws regarding non-medical exemptions. As we discuss religious exemptions, it will become clear that few religions actually specify an opposition to vaccination in their official teachings. Providing these exemptions harms those who have legitimate medical reasons for being unable to receive vaccinations, such as donor organ recipients, those with compromised immune systems, and the extremely young and extremely old. We will also discuss those harmed indirectly by the anti-vaccine movement, not just those who become sick, but also disability advocates. A daughter estranged from her own mother because of a rift opened by her mother's anti-vaccine sentiment, and activists who have received death threats for working on public health initiatives. Determining whether or not to receive vaccinations involves a set of decisions, each of which carries moral weight. They are decisions with the power to create or ease suffering. So this book also touches very lightly on moral philosophy. In this book, I have two goals. The first is to provide a more complete picture of the anti-vaccine movement, from its inception in the 19th century to present-day social media wars. This goal is undertaken with the understanding that there is a complex balance of risks that we must face when making decisions about our own and others' health, and which decision is correct can be murky and clouded with misinformation. I hope that this book brings the reader a deeper understanding of the anti-vaccine movement. The second goal is to provide a counterpoint to some of the misinformation to which the reader may already have been exposed. If you are on the fence and looking for more information, then I hope this book will serve as a good resource. If you are opposed to vaccination, then I hope you will approach this book with an open mind. 1. Is there even a problem? Is the anti-vaccination movement even significant enough to pose a widespread threat to public health? To answer that question, we must look at actual immunization rates. If immunization rates were universally meeting targets and outbreaks of preventable disease were not occurring, then anti-vaccine activists would be unworthy of notice or response. As of 2016, vaccine coverage in the United States exceeded targets for vaccination with diphtheria, tetanus, and pertussis, DTaP, poliovirus, measles, mumps, and rubella, MMR, Haemophilus influenzae B, Hib, hepatitis B, Hep B, varicella, pneumococcal conjugate, PCV, hepatitis A, Hep A, and rotavirus. Coverage did not statistically change from 2012 to 2016. For most of these vaccines, coverage was above targets of 90%, but for vaccines that required boosters during the second year of life, coverage was somewhat lower. The best predictors of vaccine coverage were not membership in anti-vaccine groups, but access to medical care, as determined by private insurance coverage, race, and socioeconomic status. In the United States, overall rates of people seeking exemptions based on philosophical beliefs are low, and religious objections are even lower. From 2011 to 2012, exemption rates for the MMR vaccine were less than or equal to 2%. Rates in Europe are similar. Although more Europeans express skepticism about vaccination, this has not, in most cases, translated into action significant enough to cause outbreaks of disease. In France, as of 2016, 41% of respondents disagreed or strongly disagreed with the statement, "Overall, I think vaccines are safe." Yet 96% of children were vaccinated against diphtheria, tetanus, and pertussis, and 89% of children were vaccinated against measles. These numbers are lower than would be ideal, but are not as bad as suggested by the level of vaccine doubt. The difference between vaccine doubt and vaccination rate is a gap between intent and action. This disparity between belief and behavior has been termed the intention-behavior gap, or the value-action gap. Many of us experience such gaps in our daily lives. Most smokers know that smoking is bad for them, but smoke anyway. We know that driving above the speed limit is dangerous, but most drivers occasionally exceed speed limits. It isn't that smokers don't value their health, but that various other factors enter into each decision to smoke. Likewise, there are many factors that affect the likelihood of an individual choosing to vaccinate. While the measles vaccination rate in France should be higher, and the French government is working to improve vaccine coverage, the factors affecting parents' decisions to vaccinate include more than doubts alone. Those vaccines that have faced difficulty achieving high coverage rates are often tied to other controversies of morality or identity. Gardasil, a vaccine against some strains of the human papillomavirus, HPV, that causes almost all cervical and anal cancers, as well as the majority of vaginal cancers and cancers of the tonsils, soft palate, and base of the tongue, became very controversial after it was approved. Several largely Christian religious groups opposed adding Gardasil to routine vaccination schedules on the basis that they believed it would lead young women to having premarital sex, which they opposed. Opposition to the HPV vaccine is probably better explained by the moral and cultural identity of those opposing it than by opposition to vaccination as a whole. The way that Gardasil was introduced by Merck & Company, Inc. may have played a role in this controversy, as well as in reporting in the media that did not properly place the data and the opposition to the vaccine in context. Merck enacted a lobbying campaign in state legislatures to make Gardasil mandatory for young girls. The campaign produced a very negative public reaction. By comparison, the Hep B vaccine, which similarly treats a sexually transmitted infection that can cause cancers, was introduced without much controversy and added to the routine childhood immunization schedule in the 1990s. The way that vaccines are introduced, as well as the cultural competency of those introducing them, to communities plays a very important role in preventing vaccine hesitancy. Despite the overall high vaccination rates in the United States, there are enclaves where anti-vaccine rhetoric has taken root, and decreases in immunization rates have occurred, leading to outbreaks in some cases. As early as 2010, anti-vaccine activists were speaking to the Somali American community in Minnesota. In April through August 2017, there was a measles outbreak in Minnesota, the largest in 30 years, with 79 cases, most of them Somali American children. This outbreak had the potential to be far worse because measles vaccination rates, while overall high, were much lower in some groups, such as private schools, where the vaccination coverage averaged only 83%. In a remarkable collaboration, public health officials worked with Somali American imams to conduct a vaccination campaign. Between April and July 2017, more than triple the normal number of vaccinations occurred in Minnesota clinics, and after the end of the outbreak, vaccination rates remained higher than before the outbreak. These results suggest that culturally literate approaches to communities where vaccination has declined can be effective in fighting outbreaks. Reports at the time showed people handing out flyers to spread anti-vaccine conspiracy theories in the Somali American community, although anti-vaccine groups campaigning in the area denied this activity. In another example, in 2014 through 2015, a measles outbreak occurred in California that spread to over 100 children, 45% of whom were unvaccinated. In the news media, this became known as the Disneyland outbreak. In California, vaccination rates had dropped from above 95% to about 92% in the prior decade, an effect attributed to anti-vaccine activism. Following the outbreak, several public health measures were taken. A law, SB 277, made it more difficult to obtain non-medical vaccine exemptions for children entering public school, and the University of California system refused to accept unvaccinated freshmen. As a result, childhood vaccination rates have risen to above pre-2004 levels. However, some counties still lag behind others in vaccination rates because there is still a cohort of children who were never vaccinated under the previous, rather lax criteria. In 2019, an outbreak spread to over 1,000 cases, a number much higher than the number of cases in the United States in any previous year since measles was declared eliminated in the country in 2000. The outbreak began in an Orthodox Jewish community in New York when an unvaccinated child returned from Israel carrying the virus. In Washington state, where Clark County saw 73 cases of measles, the state government passed House Bill 1638, which eliminated personal and philosophical belief vaccine exemptions in the state, but still allowed religious exemptions. We will see in a later chapter that religious exemptions are rarely based on the teachings of any religion and often invite parents to lie. In Rockland County, New York, a law banning unvaccinated minors from public spaces was passed. However, the ban was placed on hold. As part of the outbreak, a U.S. cruise ship, operated by the Church of Scientology, was quarantined due to measles risk, but later cleared. Despite the relatively high vaccination rates in almost all countries with vaccine doubt, Ukraine stands as an outlier, with both high vaccine doubt and a drop in vaccination rates for polio, measles, mumps, and rubella to around 50%. This drop preceded a measles outbreak. In Ukraine, vaccination is required prior to school attendance. However, it was often easier to obtain a fake certificate than to obtain a vaccination due to hospitals running low on free vaccinations. This forced parents to face paying high costs at pharmacies. More than half of the more than 40,000 cases of measles in Europe in 2018 were in Ukraine. The decline in Ukrainian MMR vaccination rates from 95% in 2008 to 31% in 2016 was astonishing. And even the current 85% rate is below that required to...
Sample complete. Ready to continue?